This presentation is about improving the function for a patient with cerebral palsy. This information has been gathered by the Movement Science 2, Group 1. Our patient is an 8-year-old girl with cerebral palsy in the chronic stage of condition. She currently gets around in a wheelchair, but has been practicing walking with a front-wheeled walker for about 30 minutes a day with assistance from her parents. While using the front-wheel walker, she can only go about 20 feet before needing a break. Currently, she requires minimal assistance for sit-to-stand, and she transfers from her bed to her wheelchair using a standing pivot transfer with her parents helping. She wants to improve sit-to-stand and become independent using a front-wheeled walker so she can go down the hallways at school on her own.
All right, so for our patient's body structure and function, we performed a growth strength assessment on her. For her upper extremity, she was a 4+ out of 5 bilaterally. However, she did demonstrate some weakened grip strength when we got her on the hand dynamometer. She measured about 10 pounds of force in the right hand and 9.5 pounds of force in the left hand. When we tested her lower extremity, her hip flexors and knee extensors, along with her ankle plantar flexor and dorsiflexors, were 3+ out of 5 bilaterally. So this led to some difficulty with balance and coordination for her. So we had her perform the Berg balance test, and she scored an 11. This is mostly due to her inability to stand unsupported for longer than 30 seconds, and she's not really able to reach out away from her body without somebody there to assist her. So this limits her when she's bathing or performing self-hygiene tasks, so she needs a shower chair and either a parent or family member providing standby assistance for her to accomplish that. She can only walk about 20 feet with her front wheel walker before she starts to fatigue, and she has trouble grasping doorknobs because of her decreased grip strength. And she also needs standby assist when she's performing a stand pivot transfer from her bed to and from her wheelchair. So this restricts her from walking the halls with her friends and playing with her brother outside, which is one of her favorite things to do. At home, she's got about 14 stairs inside and 3 stairs to get to the front door. She's a third grader who's really highly motivated to work with PT, and fortunately for her, she has lots of support from family and friends at school.
Okay, so for our movement analysis, we chose the sit-to-stand. The rationale for choosing this was because our patient had decreased lower extremity strength and poor balance. The sit-to-stand will help her reach the goals that we will talk about in the next slide. So for our outcomes, we see that she requires minimal assistance, usually from her parents, to perform the sit-to-stand. She uses her walker for stability, and once she's standing, she can hold her balance for 30 seconds with her eyes open before she fatigues. For compensations, we see that she might rock her trunk back and forth to gain momentum. She might have a hunched posture, so trunk flexion, when performing the task. And performing the task, she might also have excessive genu valgus. And we see that she could possibly use her upper extremity to lift her up as opposed to using her lower extremity.
So the main goals for this patient that she stated were that she wanted to be able to kind of ambulate around school better, to participate in activities with her friends. So based on that, we shaped our main goals around that. The first one is going to be the patient will be able to improve lower extremity strength by 2 manual muscle test levels and walk 100 feet down the length of the hallway with a front wheel walker independently by the end of week 12. So that would help her be able to just kind of walk through the halls instead of being in the wheelchair that she is now. The next goal is going to be for balance, and that we have the patient will be able to improve Berg balance score by 10 levels to maintain standing balance without handheld assistance for 30 seconds by the end of week 8. This is another thing that can help her kind of engage in more participation with her classmates throughout class. And then the last one is dexterity. So by the end of week 8, the patient will improve grip strength by 5 pounds per hand and be able to independently grip a doorknob to open a door. This is also going to help her around school, walking from class to class and getting into those doors, as well as increase her ability to grip a pencil and any other kind of fine motor craft skills that they may be performing in class.
So for our lower extremity intervention, we chose to do a D1 extension, which will help with the stance phase of our patient's gait. Because she's in the chronic stage, we chose to do 3 techniques, which would be the rhythmic initiation, reversal of antagonist, and combination of isotonic for neuromuscular reeducation. So for the first technique, rhythmic initiation, this is to help the patient move through the motion, help them learn it. So I'm going to put the patient in flexion, abduction, external rotation with dorsiflexion and there. And so this is the motion that I would like you to do here. And an extension, abduction with plantar flexion down at the foot here. So we're going to do that motion right there. Here, and then you're just going to plantar flex down. So that's rhythmic initiation. This is just to help the patient learn through the motion, and I can also add a quick stretch as I go through just to see if I see the patient starting to fatigue. The next technique would be reversal of antagonist. So what I would do is I put the patient into flexion, abduction, external rotation, dorsiflexion here. So what I want you to do is I want you to push into my hand here and push into my hand here. So don't good and relax. And then I'm going to go here, so go ahead and push into my hand on this side. Good and relax. This is just to initiate motion. The patient is just learning how to use those muscles, so not necessarily creating a motion, but we want to get the patient starting to learn how to go through those contractions of those muscles. And then lastly, for the combination of isotonic neuromuscular reeducation, I'm going to have the patient do an isometric contraction, then an eccentric contraction, followed by a concentric contraction. So for that, we're going to have the patient start in the D1 extension pattern here. So here I'm going to apply some resistance and then I'm going to match it. So then you have the patient there, hold, breathe, hold, good. And then you're going to apply some pressure and you're going to let me win. So you're going to go up, let me win. Good. And then I'm going to change my hand position. Alright, and then you're going to push into my hand going right back down for the concentric contraction. And that, because the patient is in the chronic stage, we would want to do the interventions for both the right and the left side.
For our first intervention, we want to do lower extremity D1 extension PNF pattern. Our dosaging would be 1 to 4 sets with 10 to 15 reps per unit 9 of resistance in Shumway Cook. If we notice any compensations, such as contralateral side trunk lean or lifting our ipsilateral pelvis off the mat, we would move from active assisted range of motion to passive range of motion if she really can't handle that rhythmic initiation. But if she could handle it and we want to progress, we can move into aquatic PT, adding a resistance band or increasing the manual resistance. And as we'll see in the next intervention, we include aquatic. So for 2 of the goals, we want to focus on improving the ambulation down a hallway from class to class, as well as improving her balance. So the D1 extension will address the stance phase of gait, which would be beneficial toward her goals. So after performing the combination of isotonics for neuromuscular reeducation, the patient will have increased the lower extremity strength and proprioception in 6 weeks to improve the stance phase of gait when walking 50 feet. And our second goal will be upon completing the stabilizing reversals of antagonists. In 6 weeks, the patient will improve her Berg balance score by 5 points in order to be able to stand unsupported for 2 minutes while playing with her brother.
My name is Alexandra Miller, and I will be demonstrating the rebound trampoline exercise today. I have Megan, my patient, who's going to volunteer to help us, so thank you for that, Megan. A couple things that I'll be going through is PT position, patient position, demoing, dosage, appropriate performance, and compensations. So the first thing that I want to do is just say PT position. So I will be on the side of Megan the whole time with my arms extended in case you have any balance disturbances. So Megan, for patient position, can I get you to stand on the trampoline, please? I want to note that she does have socks on right now, and in the clinic we would have shoes on. So I would get you to grip on, and this is actually perfect height for her, so that's awesome. Megan, I'm going to cue you to jump on the or on the pillows, okay? So I want you to really bend at your knees and get that jump going, okay? I don't want you to come excessively on your toes or on your heels. I don't want you to sway anywhere. I really want you to engage that core so that you are able to stand upright, okay? So can we try that out, you think? Okay, so ready, go. Good. And this would be what appropriate performance of this looks like. She's not leaning too much forward. She's not leaning backwards, not to the side. She's got a good grip on her handles right here. And she's absorbing the shock with her whole foot. Also, I'm going to check her knees. Can you do it again? And her knees are not going into valgus either, which is a possible compensation. Okay, thank you so much. So a couple of the possible compensations that we would see is maybe a forward or backwards trunk lean, side to side trunk lean for balance or loss of balance. We could see her knees going into a valgus on the impact of the jump, or we could see maybe excessive plantar flexion if she's got a weak core. So that is it.
Our rationale for this intervention is that bouncing exercises is a bang for your buck activity that has been proven to improve balance, strength, musculoskeletal endurance, cardiovascular endurance, and overall functional mobility in children with CP. Our exercise with the grip bar also has an added component of grip strength. Dosage for this exercise will be 3 times for 3 minutes, and our patient will perform this exercise 2 times a session with adequate rest in between. In the beginning, our patient may need more frequent and longer rest for a minute or longer. Possible progressions include increasing the time or duration of the exercise, closing the patient's eyes, single leg jumping, or adding cognitive tasks such as holding a conversation. Regressions include using a Therax or foam pad instead of a trampoline, standing or marching instead of jumping, increasing the base of support, or extra stabilization from the therapist. Our goals include, in 6 weeks, patient will improve her Berg balance score by 7 points to improve her postural stabilization and balance, so she is able to stand independently for 2 minutes to brush her teeth. In 6 weeks, the patient will improve her bilateral lower extremity strength by 2 MMT grades to improve her sit-to-stand so she can transfer safely. And finally, in 6 weeks, the patient will improve her grip strength bilaterally by 3 pounds so she can grip objects such as a toothbrush or hairbrush for basic self-hygiene. For our final exercise, we chose an aquatic intervention. For this intervention, the patient will be in a pool with the water level at her ASIS so that she will be 50% weight-bearing. The therapist will be standby assist and will intervene only when necessary. The patient will then be instructed to walk in the water from one end of the pool to the other while holding onto a toy ball of varying sizes. She will also have a flotation device to assist her if necessary. She will then be asked to throw the ball into a floating basket. For this task, we are looking for the step length to be equal bilaterally and that walking should be a fluid motion while using her core to maintain upright posture. Some compensations we might see would be overusage of her upper extremity, so using less core strength to stand upright, as well as hunching and rounding her back. The patient may also compensate by shortening her step length or increasing step width to assist in maintaining balance in the water. For the dosage, we'd like to start with 1 minute of exercise
and then 1 minute of rest, completing this 5 times. To progress this exercise, we could put her in shallower water so that she will be more weight bearing. We can decrease the rest time between sets, or we can even include a cognitive task, such as counting or talking to the patient while completing the task. To regress this exercise, if it was too hard, we can take out the dynamic aspect by having her do standing marches with the flotation device. We can also change the water level so that she is in deeper water. So if she was up to water with her sternum, we would unload by 75%. Some goals that we've chosen for this patient in this exercise would be by 8 weeks, the patient will be able to walk 100 feet in the pool with water level at her ASIS and standby assist to improve her ability to community ambulate. By 6 weeks, the patient will be able to successfully carry 5 different sized balls 100 feet and toss each in the noodle basket to improve dexterity to be able to grip a doorknob. By 8 weeks, the patient will be able to maintain upright posture without assistance while walking in the pool 100 feet to increase her overall balance and improve her Berg balance score by 8 points.